All right. Okay. So we're going to go ahead and get started with our first breakout session. Sorry for the delay. So just to reintroduce myself again, I'm Julia Chang. I'm one of the neuroendocrinologists and the medical director at the Stanford Pituitary Center. It's wonderful to have you all here in our breakout session. And today we're just going to let this be a free form discussion, open Q&A, just to talk about management and life changes after pituitary surgery. And that can be, whether that's from recovery from the surgery itself, endocrine questions, hormone questions, complications or things that can happen in terms of the nasal passageway that happens right after surgery, and also just dealing with just life changes and the mental health struggles that can happen as well. So, I want to let this be your opportunity to ask questions again and freeform. Yeah.
So within our support group, some patients came to me this morning and they asked me to ask you, in acromegaly patients, you see a lot of inner ear issues due to the bony changes and such. Do you have any insight on that and what patients can do to help improve this situation? I know that before I was even diagnosed, I was getting outer ear infections and I would go to the ER and they would say, "Where have you been swimming?" And I'm like, "Nowhere." And, it has greatly improved, but there's literally within an hour, we had 31 comments on that, short little post regarding ear issues within acromegaly. Give us any insight on what to do to help that situation.
Yeah. So the question just for the audience on Zoom was inner ear issues in patients with acromegaly and any insights into that, whether before or after surgery and what we can do to manage that.
So for patients with acromegaly, we see ear issues for both the outer ear and the middle ear. The outer ear, you have the bony growth, which you also see in surfers and people who swim in cold weather. It's called hyperostosis, and that can lead to outer ear infections. And then in the middle ear, we have 3 small bones, and you can have slight abnormalities with the bones with acromegaly. And one of the most important things is getting plugged in early to one of our ear doctors and to audiologists. We should get a hearing test to understand what is going on and also be seen by an ear specialist so that we can help manage the ear infections if you are having recurrent ear infections to prevent complications. There are certain procedures and things that we can do to help these patients when they have this. And if it is affecting your hearing, then we can help supplement that early on so that it's not something that's continuing to worsen over time.
Thank you. Yes.
So my wife has acromegaly. I'm not a patient, I'm patient support husband. And she's also a diabetic. She's on somatulin injection every month by me. I'm expert now. Every time she does this injection, the blood sugar goes haywire. So my question to you as a panel is, are there any things that we can do or she can do to circumvent, alleviate the impact of such an injection? Otherwise, she is otherwise on the good control for the blood sugar.
Yeah, that's a great question. So the question of certain somatostatin receptor ligands like somatulin and pasireotide actually is another somatostatin receptor ligand used to treat acromegaly and IGF-1 levels, and the impact that these medications can have on the insulin levels and glucagon and just the rise of glucagon and the rise of blood sugars that happen with these injections. Particularly these medications seems to really impact blood sugars after eating, not necessarily fasting blood sugars. And so I think, basics would be how can we best manage the diet and the low carb, trying to find something as low carb as possible that's still nutritious and enjoyable for that patient. So that's step one. Diet and then of course physical activity and lifestyle changes. Things such as, first line medications for diabetes or prediabetes like metformin may not be the best choice for somatulin induced blood sugar or higher blood sugars or pasireotide induced hyperglycemia. There might be other medication choices that can kind of target the post-meal hyperglycemia much more. So there's other medications like Januvia would be, or sitagliptin might be a more optimal choice. You hear a lot in the TV or in the press about medications like Ozempic and Mounjaro. These medications can also help really target the post-meal blood sugar rise as well as help with weight loss. And so sometimes there can be an added benefit there. So, I think understanding how these medications can particularly affect blood sugars, the pattern of blood sugar throughout the day, and which medications are going to be the most effective. Yeah.
Medications are not go short-term pill. They just
Yeah. Well, I think too, sometimes patients might see these changes in their blood sugar, maybe just for the first few days or for the first week right after the injection, and then things kind of settle down maybe toward the end of the month. But yeah, for as long as they're on that injection, it can be difficult.
Can I ask, are you counting how many seconds it takes to inject Somatuline? Because Somatuline uses nanotechnology and you're breaking the molecule. You're supposed to slowly inject it. Very slow. Okay. Because I was thinking maybe she was getting too much medicine all.
Yeah. Yeah.
But then that's a good point. I will give it slow.
Yeah. Yeah.
Yeah, despacito, like the song.
With exercise right before that help?
It varies, I think, for every person. Some people, even without acromegaly and they have diabetes or blood sugars issue, they will go ahead and try to pre-treat by exercise. I think that is maybe a little bit up to the individual and how much they can do at each time. But I always say that kind of diet and exercise are the bare minimums for helping to control blood sugar.
Hi, I'm Susie. I got my surgery done just 3 months ago, and it was really nice. When is it time to seriously consider like weight loss medication? Like, when is it time to really make that a consideration?
Yeah, that's another really great question. And I think this goes beyond our community of pituitary patients. I think it's very easy for patients to go into a doctor's office and all they hear is, like, oh, just continue to work on your diet, continue to work on exercise. But I do recognize how hard and challenging that can be, and sometimes how frustrating that message can be as well. And we have now really great tools, I think, within medicine to help people along their weight journey. And I think if you are, honest with yourself and that you have tried as much as you are doing in terms of diet and exercise, and you still feel like there is more that you would want to achieve, I think having that conversation with your primary care or your endocrinologist to talk about weight loss medications, I think that's a very reasonable next step. And these medications are now part of my toolbox of helping patients. And I think it's never too early of a conversation, really.
Steroids taken by distress, like medical distress. And so since we in COVID times right now, so when somebody who is on hormone, replacement plan, taking hydrocortisone, how much and how long do you need to take? Then when you get COVID, so how much you need to get up in the dose, and how long when you got the COVID. And then from my experience with thyroid issue, I got some medication topical, so on the skin, like patches and it doesn't work. I found out my way because the skin changes and it doesn't absorb medicine or even pollutant, I guess. So basically, the structure of the skin changes and it's not accepting any medication through the skin.
Yes. So the first question about how to stress dose hydrocortisone and steroids in times of illness such as COVID. So I always say that as soon as you're not feeling well, to go ahead and double or triple your dose for usually at least 2 or 3 days. It is individual, I think, for each patient. You know, some people actually with adrenal insufficiency, they seem to get by actually with not having to stress dose too much. They know how much over time that their body may need in terms of steroid replacement, but I think it's never a bad idea to give yourself some extra doses to help you recover from that illness. Usually, I say at least 2 or 3 days, or until you start to feel better, and then you can start to come back down on your normal dose. Of course, if you're really not feeling well and you're nauseous, throwing up, that would be a time where we would recommend maybe even taking the injection of the hydrocortisone, the Solu-Cortef that you might have. And I say to even do that, on the way to the emergency room, bring it with you to the waiting room. I've been on the phone with parents and they're telling me that the doctor or the triage nurse has not seen them yet and they're waiting in the ER for 20 minutes, but they have their Solu-Cortef with them. Said, just give it to yourself now. So I think that's just, having that education every time in the visit, stressing that, especially for people who are a little bit more sensitive to needing more steroids. And then your other part about thyroid topical gel or pad, that's unusual. I have not really heard that as being given for hormone replacement. That sounds like maybe, okay. Yeah, the thyroid topical replacement would be very, okay. Uh-huh. Oh, I see. Yeah. So testosterone, there's different formulations of testosterone as well. And so you've heard, gel. Yeah. So there's gel injection. Patch is actually not as available anymore. That was discontinued. There's also now oral testosterone that's available as well for those who might have difficulty with injections and gel. But yeah, I do find just sometimes that the topical testosterone gel doesn't always get readily absorbed very well, and you can have very fluctuating levels. And so when I see that someone's not responding to the gel, I usually recommend to switch to a different formulation. So that's not too uncommon.
There's a question on the chat here regarding hypothalamic obesity following, in this circumstance, resection of a craniopharyngioma. And they're wondering about any new treatments, anything in the pipeline, but the GLP-1s, generally being ineffective for this. Do you see anything else kind of coming down the line to treat this specifically?
I don't know if you want to comment on.
No,
No,
go
okay.
ahead.
So a lot of questions about weight maintenance and weight loss. So yes, we do see hypothalamic induced obesity, not uncommon or not uncommonly, especially in patients who've had pediatric pituitary tumors or craniopharyngioma. And there's varying approaches that have been tried in studies. And so some of the more common medication options might be just like things like metformin, which is not the best medication for weight loss. We really kind of consider it more weight neutral, but it can help maybe at least with some weight maintenance and then also with blood sugars. There have been some studies using dextroamphetamine, which is kind of similar to a stimulant, to help with weight loss as well. And so there's some success with that. But I think the weight loss that you get from these medications is probably going to be pretty minimal. So when you look at studies, they say 5% as being successful, but in real life, 5% is usually not that successful for somebody, you know, especially if they're starting at a much higher weight. And so I do start people on GLP-1s if they've tried enough with diet and exercise. That's already been part of their long-term plan. And you know, we can see how that goes for them.
Yeah, I would just add that I don't have anything to add how to treat it, but I can really comment on how to prevent it. And patients with craniofaryngiomas, especially pediatric patients, these tumors are embedded within the hypothalamic tissue, so they are very difficult to remove. And traditional approaches to a craniotomy very often cause damage to the hypothalamus and hypothalamic obesity, which can be really devastating. The endonasal approach comes from below. You can really separate well the tumor from the hypothalamus and have much better results. We are barely seeing hypothalamic obesity or hypothalamic damage these days in pediatric patients when you do an operation through an endonasal approach, when you do it well. So it has changed, fortunately.
Catherine, I actually would like to maybe hear, I'm sure that many patients come to you with, you know, questions about changes with their weight and how it affects them in terms of their image of themselves, body image, their relationships with others, and how one can talk through that or how one navigates that.
Sure. Would people agree with that question? That those that have struggled with changes to physical appearances or weight gain as side effects through medication, and for both men and women. So when a client comes to see me, we definitely address the reality of that, the feelings around that, and also looking at where the patient can kind of be in that advocacy piece of what can I do? Is there anything I can do? Am I making poor food choices? What can I do to contribute to fighting against this? Or is it just something that I'm going to have to accept and cope with? So I like to work with the patient really around, is there anything that I can physically be a part of in dealing with the weight loss? Does that help that answer? Right.
Surgery in 2000. Hi, this is Fen. I had my surgery in 2021, and then following the surgery, I think the regular process is that I had my MRI once a year and my hormone level check. Then after a couple of years, then I don't need to check MRI anymore. But my question is that what should be a red flag in my daily life that I should think about to retake the MRI? Because as a patient, I always worry about, oh, what if the tumor come back again? Just want to learn your perspective about that. Thank you.
Yes. So thank you. Yeah, great question. So when you have a functional tumor, let's say acromegaly or Cushing's disease or prolactinomas, you can just, and you're in remission, and you have normal levels. I always like to do an MRI 3 months at least after the operation to have a baseline. But if you're in remission, I think you can just follow with blood level, with hormonal levels, and if they raise in the future, then do an MRI. But your hormone levels remain normal and you are doing well, you can do MRIs, but I don't think it's necessary. It's just a burden to you and inconvenience. I don't really think it's needed. Now, patients that have non-functional tumors, that's a different thing. We have no marker to see whether the tumor is going to grow back or not. In those cases, we keep doing routine MRIs. How to space them depends on mainly 2 factors: whether, number one, whether the tumor has been completely removed and there is no residual, it's a clean MRI, in which case we think the chance of the tumor growing back is lower. We might space them out. And 2, the tumor type. Some tumor types have some characteristics that make them more prone to grow back than others. And those we want to keep a closer eye. Thanks.
Hi, my name's Trevor. My wife has a papillary craniopharyngioma. We are looking at potentially radiation or a third surgery or BRAF MEK inhibitors Thanks for the referral. And I guess my question is in relation to the fact that like, as a supporter, we also have an 8-year-old daughter. We're going to be gone a lot or going through a lot. Do you have specific suggestions as to like, she was 6 when we started, now she's 8, and this is becoming routine in our lives, but I don't want her to be scared of this being routine in our lives. Do you have thoughts as to how we might address that with our child?
Do you want to address that?
Catherine can answer that one if you want.
So first, I want to make a quick comment, which chronopharyngioma are not hereditary. That's something you can have peace of mind that the fact that you have a chronopharyngioma doesn't mean your children have a higher risk of getting a tumor like that. It doesn't work that way. The first thing, then how to cope with that? Maybe you want to comment on that?
I'll speak to that kind of that would be a psychosocial stressor, right? Way kind of high up on the list, but good to hear that there's no genetic connection. I think it's a dialogue that you have, with your partner, and depending on how you parent and co-parent your daughter, how open are you? How mature is she to be able to kind of understand what we're going and maybe you kind of, it's not just about what mommy's going through, what we're going through. We're a family, right? Looking at it as a family, we're going to work together to kind of support mommy through this. And I just want to let you know, mommy and I may need to do some travel, but we're right here, and just reinforcing in her little 8-year-old brain, right, that's developing, that she's safe and secure and okay. Okay. Is that helpful? I'm a big believer in just open dialogue, even with children, so they don't think there's secrets, because children, when they think it's secrets, they make it about them and they think they did something wrong. So we want to stay away from that road.
Hi, my name is Cindy. I had my surgery 27 years ago, so I was in a different era. So I've learned a lot about the new era today. My question is, has anyone done any research as how things change as you get older? Because my body's changing, so I find that I'm not quite as stable as I once was with my pituitary issues.
Yeah, that's a great question. And there is a lot of research just about hormones and aging and what's the appropriate, hormone replacement for older individuals. When someone is in their younger years and maybe what we call kind of premenopausal in age, we talk about estrogen replacement and progesterone replacement, and then all of that kind of goes away, at some age in the 50s. But we recognize that people might still feel like they have some symptoms of hot flashes and still needing some amount of sex hormones. So that's a discussion that we have just based with every individual at that age and their risk factors, and if it's appropriate at what age that some those hormones could be tapered off. Things like growth hormone replacement can also change as one gets older as well. The normal IGF-1 level can shift down with age, and so maybe we're targeting different levels, different doses as one gets older. And then also just recognizing, as maybe other, metabolism processes slow and weight changes that may not necessarily be related to the pituitary hormones directly, how that might affect your doses of thyroid hormone or steroid as well. So, and, as sometimes we're again more sensitive to external insults to the body, like dehydration and illnesses, and being very mindful and on top of when someone or when you might be going into an adrenal crisis or really need that stress dose, and now having to be kind of more cognizant of that process.
Could you also tell me what is the percent or chance of getting a pituitary tumor to reoccur after 27 years? I know it's possible, but what are the odds?
I believe that if your MRI is clean, is being clean all these 27 years with no residual tumor, the chances are close to 0. Yes. We typically quote the risk, in my experience, the risk of the tumor coming back is about 5% over the next decade, generally speaking. But of course, that just putting everybody together, and every tumor is different, every patient is different. Some tumors we said are more aggressive than others. Just a side comment, as you mentioned the age, I can make a confession that we recently operated the oldest patient with a pituitary tumor. He was 89 years old. And I wouldn't think I would operate on a patient that old, because at 89, why would you take a patient through an operation? But this patient of an Irish, he was Irish and living here in the United States, but Irish background and very strong genes. His family lived over, in the mid-90s, and he had a big tumor and he was getting blind. So we did an operation and he actually did really well. He was discharged 2 days later and he recovered really well. So you can actually go through these operations at very advanced age, as long as your health is reasonable. Yeah.
So the oldest person, 2, and he diagnosed with acromegaly. Yeah, still alive. No, he actually looks perfect. But he can
Hi. I had a pituitary tumor that went into an apoplexy. That's how we found it. And since then, that was in 2014 was my surgery. And I have been just not well managed on oral steroids and all of that. Tried growth hormone and all the additional, and trying a variety, dexamethasone versus prednisone versus hydrocortisone. Trying to find like that circadian rhythm, what are different things, shorter, more frequent doses, but still struggling with kind of fairly frequent crises and like lots of symptoms. So in doing some research, I've heard about and been exploring using an infusion pump, insulin pump, but for the purposes of cortisol. And I'm just curious what you guys know about that and thoughts on that.
Yeah, that's a great question. That was actually immediately where my mind went as you were describing your situation. So hydrocortisone infusion pumps are not very common. I think most endocrinologists don't have very much experience with using hydrocortisone infusion pumps. There are case reports and case series of patients who are managed on hydrocortisone pumps. I think, kind of similarly to your talk, Jill, where you discussed unmet needs in acromegaly, I think there are many unmet needs in hypopituitarism. And I think this is one of them, where the kind of standard traditional hydrocortisone twice a day dosing doesn't work for everybody. And we have to be creative in terms of solutions with steroid dosing. And so whether that means, having a nighttime dose to get you up in the morning, or some people, if they're not able to find an infusion pump or have a provider who knows how to manage an infusion pump with hydrocortisone, where there's really not very much guidance. I've seen people kind of split their doses throughout the day, but that can be very taxing, to have to think about that throughout the day. In Europe, there's actually now kind of slow release preparations of steroid as well, hydrocortisone. And I think that would be interesting for that to come to the US as well. And maybe that will be in the future. But so far outside of kind of case series and, a few individuals, it's not yet standard of practice, but I could see maybe in the future where we're hearing more about that.
Hi, my name's Heather. I just had a couple of questions about hormones like oxytocin. My first tumor was in 2001. No one's ever tested me for that. Do I need it? I mean, it's the, love hormone also, and, being close to people. And I just wonder if, you ever would replace that. And then also, I see Dr. Blevins at UCSF, so has me on dexamethasone. Just about everybody else uses hydrocortisone. So I'm just wondering if your thoughts about that.
Yeah, it's a great question about the oxytocin. It's the one hormone that we really don't talk about in the endocrinologist's office. And I think it's because we don't have a standard way to measure it or a good way to measure it even. The oxytocin levels fluctuate. They're not stable in the assay or in the lab. You often have to get kind of pooled samples of serum. So it's hard to measure. It's hard to really get a sense of oxytocin deficiency. And there's also not great ways to replace it. You heard about maybe oxytocin infusions in labor and delivery, but kind of outside of that, there's not many standard ways to replace oxytocin. There was a study recently done in a group in Switzerland where they looked at people who had diabetes insipidus or AVP deficiency, and also diagnosed therefore with oxytocin deficiency, and trying to replace them with oxytocin. I can't remember if it was tablets or intranasal, and kind of seeing just survey responses before and after. And it was very interesting. And I think we might see more of that in the future, but it's still very early stages. But yes, so far it's not part of our typical hormone armamentarium.
I mean, I feel like we should probably.
Yeah, I don't know if we have a great answer for that, because so far we don't have a good way to replace that. But I would be curious to see how subjectively and how quality of life may change if that becomes more standard practice. And I will say that you will find lots of different hormones in compounded pharmacies, including oxytocin. And actually, I've talked to some of my colleagues in reproductive endocrinology and urology, and sometimes they're prescribing these, kind of actually to my surprise, and for intimacy or quality of life. And it seems, when I ask them about it, it seems 50-50. So, yeah. Oh. Yeah. So, there's different approaches, I think, to steroid dosing. Again, I think certain providers have their own preferences. Dexamethasone is very long acting, as you've heard, and it can be very potent as well. And I think that is kind of the main fear or complication that we can run into with dexamethasone is just weight gain over time and iatrogenic Cushing's, or just Cushing's because of medications, or Cushing's-like features because of medication. So that's the one drawback with dexamethasone. How well it works when it's a very low dose, I think depends on that person. Again, everyone's a little bit different. I think most of our patients do very well with hydrocortisone, and we try to dose it in a physiologic manner. And in someone without adrenal insufficiency, we see kind of a higher peak of cortisol in the morning and a slightly lower peak in the afternoon. And that's why we're always telling you to take it twice a day, once in the morning and then once in the mid-afternoon. But for some people, the hydrocortisone is not the best option, and the longer acting one is a little bit better for them.
So I had my surgery 2 years ago for acromegaly. I don't know if this is actually an answerable question. Maybe it's better for a support group, but without realizing it, I've had probably symptoms since 2003. And even when I came to see Dr. Fernandez and he asked me questions, I know I minimized the answers, like, do you have this? You have this? I was like, yeah, and I still tend to do that. So, and then we had talked about in Catherine's presentation, thank you, that not everything is acromegaly or it's related to your pituitary. So you don't really know. But with that said, I'm on my second, 6 months ago, I had a hip replacement, just had another one a couple of weeks ago. When I had seen an orthopedic surgeon, he was like, oh, you have great joint spaces. You don't have any arthritis at all. And I've been told that a couple times. we'd always see osteophytes and different things on x-rays, but like, meh, no big deal. And then I see this other orthopedic surgeon. He's like, your hip is terrible. Why did you wait so long? And the other one was too. So all that's fine. But I guess my question is it's kind of like we have to be our own expert, but we don't necessarily know how to be our own expert. I've been, I had rising blood sugars with a normal A1C for years, and I was 40 pounds less than I am now. And I thought, oh, my high blood pressure was because, oh, I'm a nurse, I work night shift, so I always had excuses for everything I had other than like, who's going to think you have a tumor, right? So then when I just had my hip replacement 6 months ago, the anesthesiologist could hardly intubate me. He really struggled to intubate me. He said my epiglottis was gargantuan. I'd never been told that before. And maybe it has nothing to do with it, but like, what else is coming down the pike that, that I have to know about to tell someone, or to advocate for myself? I mean, does that kind of make sense? Like all these things. And I have an endocrinologist because I had a multinodal goiter that was removed in 2018. She didn't even pick up on the fact I had acromegaly. So I don't know. I don't know how, so I end up having this difficult intubation, and they're like, well, you need anesthesia consult now for all your surgeries. So it's just, I just keep wondering what else is coming. And is that something that anybody has an opinion on?
Yeah. So many of our patients have hips, shoulders, multiple joint replacements. I can tell you what I think. Well, so in our patient-focused drug development program, it clearly showed that our symptoms don't match IGF-1 levels. And in a lot of research, that's why doctors also need to not just pay attention to the numbers, but also our symptoms. I tend to wonder if for the last 12 years, I've not only focused on growth hormone, I focus on the ghrelin hormone. And ghrelin has been tied to inflammation. It's been tied to sleep disorders, sleep apnea, all these different things. Ghrelin is within the growth hormone spectrum. It is a stimulating hormone for growth hormone. And for years, they thought that growth hormone and ghrelin were the same thing, but they found that it's just a slightly lighter molecule. I personally think that, even 25 years down the road, they're going to say, we've learned so much, and maybe we should have been measuring these things too. I think for an acromegaly patient to do really well, they have to have every single one of their growth hormones within the growth hormone spectrum, not just one. And I think that might be why the reoccurrence rate might be higher in acromegaly, because they remove the tumor, but they don't do anything about the high ghrelin levels. Post-surgery, a lot of patients gain a lot of weight. It is so common. And
I live out of state, so it's none of you people.
Right.
But my endocrinologist had nothing other than eat less. I mean, she's very nice about
Yeah.
it, but I'm like, I don't know that it was possible to eat that much to gain this much weight.
Right. Well, and I truly do believe that weight gain is a disease. It is our body not working properly that causes. I don't think that anyone wakes up every morning and says, I want to eat, and be hungry all day long. And post-surgery, so many acromegaly patients are starved. I mean, we'll eat and 30 minutes later, we'll be hungry again. Really.
That's why I was like, why is this weight coming up?
Mm-hmm.
Anyways,
but I think that it might be, I can tell you that there are companies right now, and actually I got an email the other day, there's a study that's going on within acromegaly where one of the companies will send a nurse to your home and will draw your blood, give you $100 for your blood. One of the things that they'll test is the ghrelin hormone. And we need more study regarding these rare conditions.
and the way that they actually work within the body, not just the medications. We need more understanding about the disease themselves, in my opinion.
Well, and I think part of that was my limited understanding is that people with acromegaly, we tend to have bigger joint spaces initially. So we don't look like we have arthritis, but then we actually can have arthritis. And that's what my second orthopedic surgeon said. He said, I bet your other guy didn't think you have arthritis.
Mm-hmm.
Properly. I don't know.
So I can tell you,
Special joint, different stem because I had like almost a very narrowly, a lot of narrowing femur. So it was a difficult joint replacement too. But like he knew a lot about it. But I just
yeah, you have to know about acromegaly and you have to get to the right care teams. And I think that is a major, hurdle for patients is to find the right care teams. And patients come to me that have had multiple surgeries, and I try to guide them to more knowledgeable teams. And I don't hold any of the other doctors, it's just that when you don't know, you don't know. And the more when you go to a center of excellence, a pituitary center of excellence, the amount of patients that they see, they just build a better understanding. And they're able to give the patients better care because of their understanding and what it takes to manage a patient well. And the whole thing about this is our quality of life. We want to gain back our quality of life. But for myself, whenever I was diagnosed with acromegaly, I had a size 11 shoe. And whenever I had my pituitary surgery, I went down to about an 8.5, 9. And I was thrilled with that. But when I started focusing on the ghrelin hormone also, I'm back to my high school size 7.5. And I never thought that I would see a 7.5. And it's all about making sure that every single one of those hormones within the growth hormone spectrum are within the normal range. I think that although we're doing our best, scientists have told me that they know about 8% of how the body works. And I don't know, which means there's about 92%. And I've been blessed. I'm allowed to, I go to Pituitary Society meetings and Endocrine Society and ACE. And at every single one of these meetings, I not only, corner people regarding acromegaly, I also focus on the ghrelin hormone. So.
Thank you. 8% is definitely optimistic.
I have a question, a couple of questions actually. One is from our online community in and around issues with prolonged elevated exposure to elevated growth hormone. So do you have any information regarding whether or not acromegaly patients are at an increased risk for functional neurological disorders or central sensitization due to their system being exposed to years of elevated growth hormone? And then I would like to add an additional kind of addendum to that, which is someone who is diagnosed with a pituitary tumor that is functional and is making excess growth hormone. Do you consider that person to still be active acromegalic following pituitary surgery with a reduction of your growth hormone and IGF into the normal range? Does that person consider, is it more this person has had a history of acromegaly, or should many of their symptoms resolve when their hormones are now back into the normal range?
I might start with the second part of that question first. So, the classic teaching is that, okay, now you've had surgery, your IGF-1 is no longer high, it's back to the normal range. But I think there is something to be said, like what was the normal for that person, pre-acromegaly or pre-formation of their pituitary tumor. And we're not in the habit of checking IGF-1 like we are with like cholesterol. So we don't really we wouldn't really know that. And so I do have patients, post-surgery whose IGF-1 is normal, maybe on the upper side of normal, and they feel like they have their symptoms coming back. And so maybe, IGF-1 sometimes is not always enough as the only indicator. And then so many times it's good, but more and more I've been also checking growth hormone, looking at growth hormone post tolerance tests to see if they're suppressing normally, and using that as really part of my toolkit as to whether or not someone is truly kind of has a normal growth hormone axis and response. And then the first part of the question of prolonged exposure of growth hormone and functional neurologic disorders, I think I don't know how to necessarily answer that. And that can take many different forms. And so I'd be a little bit curious as to kind of maybe what types of functional neurologic disorders they might be referring to, or if anyone here has heard more about that. Yeah.
I don't think there is any evidence of a known neurological disorder related with acromegaly that I know of. Yeah, sure. Peripheral neuropathy, yes.
Yeah. Okay. Yes. Oh. Yeah. So neuropathy can certainly be common with acromegaly, especially carpal tunnel syndrome, and the swelling, soft tissue swelling that can happen. And so that actually can be the first presenting sign, or one of the earliest signs. You have people being diagnosed with acromegaly very, in your office today, but they had bilateral wrist surgery for carpal tunnel 15 years ago. And then neuropathy from maybe diabetes or higher blood sugars over time as well.
No, I had a microadenoma tumor that was, I had the surgery in February, and I was told that it grows 1 millimeter a year. And so I was wondering, is that a comment on that? And also whether how many millimeters it needs to grow before I need another surgery?
So it's a rough estimate that pituitary tumors grow 1 or 2 millimeters a year. And as I often tell many of you, my patients, you can do an MRI a year apart and you don't see any growth because a millimeter is such a small difference that you look at the MRI slices, they are typically 3 millimeters, the standard. You can do that 1.5. So imagine it's below the limit of the resolution of the MRI. So often you have to wait 3 to 5 years to have a 3 to 5 millimeter growth to then see an obvious growth. That doesn't mean the tumor didn't grow during that period of time. It means that it was growing so slowly you couldn't detect it until enough time passed. In regards to the tumor size, typically the magic number is 20 millimeters or 2 centimeters is when a tumor is already putting significant pressure on the optic apparatus, and 2 centimeters. Now, it can be different because sometimes tumors grow down into the sphenoid sinus, then you can have 2 centimeters going down and then has no impact. But if you count 2 centimeters from the pituitary up, is when the optic nerves are stretched. At 1.5, it starts touching the optic apparatus. At 2 centimeters is when the optic apparatus is being thinned out, stretched, and you start having some peripheral visual loss, and therefore surgery is necessary.
Hi, my endocrinologist found like a 1.5 millimeter growth, and I'm Bernadette. Dr. Fernandez-Miranda looked at it and believes apparently it's not growing, it's shrinking because it seems to have exploded. And I had awful headaches and whatever, an adrenal crisis, someone called it. So I'm just curious, how often does this happen, that you have that apoplectic or exploding kind of tumor? And can I expect things to happen, or is there not any further research on this?
So apoplexy, for those that are less familiar, means is another word for a stroke. So it means a tumor loses its blood supply. And it's typically because the tumor is outgrowing the blood supply. And then it can manifest as a what we call ischemic apoplexy. The tumor strokes out and then swells, or a hemorrhagic apoplexy, where the tumor actually not only that, but also bleeds inside. Either way, it causes an sudden increase of pressure within the pituitary area. That's an increase of pressure causes, compression of the pituitary tissue gland, pituitary gland tissue, and therefore often patients present with a hypopituitarism, low cortisol levels especially, visual loss, sometimes double vision from the compression of the cavernous sinuses. It is considered a medical emergency because the first thing you need to do in apoplexy is treat the steroid deficiency. That's the very first point. And if you have, I didn't mention, but the pressure also causes a very severe headache, probably the worst headache of your life. If you have such a bad headache, visual loss, we typically like to operate on these patients. The sooner the better. So typically, within 24 hours, we like to do an operation for those patients. Some of them, if the symptoms are mild, you can do just with the steroids, and they might resolve on their own. The tumor will dissolve. A tumor, like in your case, I believe, had apoplexy and is shrinking, it's unlikely it will grow or cause apoplexy again in the future, but it can. So you still have to watch it with some regular MRIs every year, etc., because the risk is still there. Yes.
Maybe the difference of management of renal insufficiency in a child versus an adult. And do you dose, let's say, 3 times a day versus 2 times a day? Number one fan online asking.
So it depends on the age of the child and the weight. For our younger patients who are much smaller, so their steroid dose may depend more on body surface area. And then with adults, sometimes we do still actually use body surface area, especially where maybe 15 milligrams of hydrocortisone per day may just not be enough for someone who's a little bit larger. And so we're using definitely more weight and body surface area to determine our steroid dosing for younger patients who are smaller. Yeah, I'd probably have to ask my pediatric colleagues, but I do think that, yeah, I do see kids being more on the 3 times a day. And I think at some point, what the steroids might be, if they can be combined and there's no change in their energy level, or if it starts to disrupt their sleep pattern. And then as they become older and they go through puberty, that might be a natural time to start to change.
Okay, we probably should finish the session because I heard them clapping. So probably that means they finished theirs. So let's take a quick break and go for the next one. Okay.
But it's such a big difference.